of and our honorable lecturers and our honorable participants. Welcome to the open lecture from Prof. Frank Abbas and Prof. Van Wittgenhoff. For today's lecture, it's a great pleasure to be your master of ceremony for this open lecture. The first session will be delivered by Professor Frank Abbas, and this session will be, and as the chairman for this session, will be guided by Dr. Tita to Dr. Margarita Nastiti. Time is yours.
Good afternoon. Thank you very much for Pak Frank and all. It's really great for us to hear for the open lecture. So the audience here, they are the residents of the specialistic degree for various specialistic training. We have the oral maxillofacial surgery residents and also for endodontic and conservative dentistry and periodontology, of course, and from orthodontics and what else of the pediatric dentistry, anyone that not be mentioned yet, from prosthodontics. So basically they are the specialistic degree students. Yeah. Okay, it's really great for us to have Pak Frank. Yeah, that also mentioned Professor Frank Abbas. We have a long story of collaboration between the Faculty of Dentistry Gajah Mada and also from the Dentistry Department from Groningen University. And we usually call him Pak Frank and also Pak Yan. Yeah. Okay, today we have two kinds of lecture. Pak Frank will share his experience about the smile design, a periodontal, orthodontic, and prosthodontic approach. And with Pak Yan, he will give the lecture entitled Systemic Antibiotic Therapy of Destructive Periodontal Diseases. Before we start the lecture this afternoon, may I read your curriculum vitae first, Pak Frank? Professor Frank Abbas obtained his DDS degree in 1979 from the University of Groningen, the Netherlands. He did his specialty training in periodontology at the University of Amsterdam. Now the university is called Academic Center for Dentistry Amsterdam, or it is recognized with the name of ACTA. It's a very famous name, yeah? Including a PhD thesis on susceptibility to periodontal diseases. In 1989, he was appointed as specialist in periodontology by the Dutch Society for Periodontology. Pak Frank was active in many professional committees, including the Examination and Registration Committee and the Board of the Dutch Society for Periodontology. He is founding member of the Clinic for Periodontology in Amsterdam and maintains practice as periodontist and a multidisciplinary approach of oral rehabilitation. At the Department of Periodontology of ACTA, he acted as head of the clinic and co-founder and coordinator of the MSc program in periodontology. He is fellow of the Royal College of Surgeons of Edinburgh. His research focus is on susceptibility to periodontal diseases, in particular the relationship oral microbiology and clinical periodontology and also on regenerative and surgical technique in periodontal plastic surgery. Furthermore, he is involved in research on the periodontal general health connection. He published in all major periodontal top journals and lectures worldwide. In 2003, he was appointed as professor in periodontology and maintains the position at the Center of Dentistry and Oral Health as a chairman from 2007 to 2014 of the University Medical Center of Groningen at University of Groningen, the Netherlands. Okay, please, Pak Frank, this is yours. Please.
Selamat siang, dear colleagues, friends. Thank you, Dr. Tita. We know each other for a long time. I would also like to thank Bubundi, who started this international cooperation between Groningen and Gajah Mada. And I would like to thank Dr. Henry Susanto for taking extremely good care of us during our stay here in this beautiful city, I would say, the pearl of Java. And he has shown us all the highlights and the nice things that can be seen in the very, very rich history you have, especially in this part of the world. Now, it's a bit strange to talk about smile design in a country where everybody is smiling at you. And I've seen so many smiles, so many nice smiles, especially from the ladies. And so I was wondering what's the purpose of my lecture. But sometimes there can be some things changed on a lecture. Sometimes a person is not satisfied with her or his smile. So this afternoon we are going to speak about a couple of things. And I'm turning this a bit so I've seen the slides before, but it's nice that I'm in coordination. The program will be that we first have to analyze the patient's complaints and the patient wishes, including facial and smile analysis and design. And then we'll talk about orthodontics and periodontal inflammation. Periodontal plastic surgery will be a topic. And then periodontal plastic surgery and restorative dentistry. And you will see that all these disciplines in most cases are needed to come to a nice smile. Now, we start with the patient. This patient first came to the orthodontic department. And she had a complaint. As it was a Dutch lady, she complained in Dutch. And she said, there's a space between my teeth, my upper teeth. This is growing bigger. And also my front teeth are loose, and this is they become increasingly loose, and they also move in a forward direction. And that's what people tell me, that I have longer teeth now. I don't like them to tell that. And also my speech is altering. I don't know the English word, I'm slissing. What's it is? Like talking like this. She was not able to pronounce the S in a proper way. And it's difficult for me to close my mouth. And she says this is very, very disturbing to me. And I think it's terrible. What can be done about it? Now, she's flaring upper teeth. That's the diagnosis. She's got flaring upper teeth, including diastema, protrusion of the front teeth, extrusion, she got longer teeth, and there's also increased mobility of the teeth, and there's an altered speech, and the lip closure is difficult. These are the objective things you can establish, you have to establish This was also part of her complaint. And it's progressive. But what's the etiology? What's the etiology, my dear colleagues? I think we all agree that the etiology is caused by a severe adult generalized periodontitis, as can be seen on this X-ray. What happens is that the teeth move to a different position because of the lack of periodontal support. Teeth always have, as the orthodontists know, but probably all of you know, they always have a reason to be in a particular position. And if they don't have a reason, they would probably be in a different position. So there are different forces acting on the teeth, which makes them to be in a certain position in which the forces are in balance. Now, which force is the biggest? That's the force from the lip. And this force is compensated by the force of the tongue. No, the force of the tongue is the biggest. The force of the tongue is the biggest. The tongue tries to protrude the teeth, and this is compensated by the force of the lip and the periodontal support, the amount of periodontal membrane, how much support is there. Now, if you have a compromised periodontal membrane, so you have lost support for the teeth, periodontal support, then the force of the tongue wins. And because this is stronger, it will push the teeth in a forward direction. And it also loses contact with the lower teeth. So they have the chance to get longer, to flare out and to extrude. How can we restore the balance? In former days, these patients were sent to the orthodontist, and if the orthodontist didn't notice that there was periodontal disease, they started to treat. It's very, very quick treatment. It can be done in a very short time, because there's a lack of periodontal support. But then you will be really in trouble, because you're moving teeth in a situation in which there is periodontal inflammation. And if you do so, the rate of the periodontal breakdown will increase to a dramatic rate. And at the end of the orthodontic treatment, you will lose all your teeth. There's so much additional breakdown on the teeth that you will lose them. So what needs to be done as a first step? First, to restore the periodontal condition, so there's a healthy periodontium. That's the first step. And then, including a lingual retainer, this will compensate for the force of the tongue, and then the teeth will stay in the new position you have put them. Okay? So these are, in general, the basic steps in dentistry. You start with the diagnosis, including all these things: anamnesis, stress, look upon the smoking habits, take radiographs, you do clinical measurements, plaque, pocket depth measurements. Then you start with the infection control. With the infection control, with debridement, plaque control, antimicrobials. I don't want to go into that too much, because my colleague A.J. van Winkelhoff will talk about this topic and on which indication you should use antibiotics, etc. But this is part of the infection control, and once the infection is under control, this is the moment to start to restore the periodontium and the function of the teeth, including orthodontics, periodontal plastic surgery if indicated, implant surgery, crowns and bridges. This is always the last step after the infection is under control. I think we all agree on this. So, after treatment, after periodontal treatment, the infection is under control in this case, and this is the right moment to start the orthodontic treatment. Now, the first complaint, the diastema, what can be done about that? We have to close the diastema. So, fixed appliances are applicated in this patient to close the diastema, as can be seen on your left hand. Then we should take control of the protrusion by retruding the teeth, as can be seen in this picture on your left. The extrusion is controlled by means of intrusion. I'm going into the mechanisms of this principle later on, but this is in short how this patient was treated. So the orthodontist takes care of all these things. The teeth are intruded, and by doing so, the function is restored. There's improvement of the speech, there's improvement of the lip closure, etc. But she's still complaining about black triangle disease. It's not a disease, but patients are complaining they don't like these large black triangles in between their teeth. Now, what can be done about that? Are patients complaining about black triangles in Indonesia as well? I'm looking to my orthodontic colleagues. The answer is yes. What can be done about this? About the black triangles. That's interproximal stripping. And why are we doing that? Why are we doing this interproximal stripping? And of course, this is the best to do when the orthodontic appliance is still, or the slots are still in. You take off the thread, and in this case, you see that the teeth are stripped and they are brought together. And by doing so, the black triangles will close. They will fill up with soft tissue. This is before we had a contact point, as can be seen here. This is also here on the other side. We have a contact point, which is very much to the incisal edge of the teeth. And after, we have a contact plane, as can be seen on the right hand, and the orthodontic appliance has been removed. In this situation, we have a contact plane, and by doing so, that's the basic principle. We follow Tarnow's rule. And Tarnow's rule says, and this is a very important clinical feature, and it works in every patient, if you bring up the contact, the most apical contact point, or a contact plane in this case, more close to the bone, to the alveolar bone ridge, and this distance is 5 millimeters or less, then you will always get a fill of the interdental papilla. The tissue will just grow in. If the distance is longer, if you have a longer distance, if it's longer than 7 millimeters, you will always end up with a black triangle. So what you should do is bring up the contact point or contact plane in this situation to a more apical position. So have a sharp look at the contact points. It's very simple to strip, bring the teeth together, and the tissue will grow in. And you have a nice result. And of course you have to use the lingual retainer on the upper teeth, and this should be done lifelong, for lifetime. And then there's again balance. So the teeth in this situation, they simply cannot move, and they won't move because there's a balance between the forces that are acting on them. Okay. So this is before and this is after, as you can see. And what you often see is if you have treated a patient successfully, give her back a nice smile, then also she has a more expression in the face. It also has an influence on the way she's smiling and the way there's no reason to subconsciously hide a situation by the lip and that kind of things. So she is a happy lady now again. I must say that in aesthetic dentistry, we focus a lot on the upper teeth. We take photographs of the upper teeth. But if you look at epidemiological studies, this is a study of Zachrisson from 1998 already, then you see that at younger age, under 30, you show your upper teeth and you hardly show your lower teeth. While at older age, during a normal smile, a normal function, you mainly show your lower teeth. And this changes around the age 40 to 50. Then the visibility of the central incisors in the mandibula in the lower jaw are more than the visibility of the teeth in the upper jaw. So this is really to take account, because if you concentrate only on the upper teeth, and patients get older, or you treat an older patient, then you also should have attention for the lower teeth. I'll give you an example. Donald Trump is just showing his lower teeth during talking and smiling and that kind. He has to do like this to be able to show his upper front teeth. In normal function and normal smiling, he just shows his lower teeth. Now this was really a model in the 60s. When I was a young guy, this was, well, everybody in the whole world was in love with Brigitte Bardot. When I asked my students, around the age of 20, nobody ever heard about Brigitte Bardot. But my generation, and I see some smiling faces in the audience as well, everybody knows Brigitte Bardot. Beautiful upper teeth. She had a couple of other beautiful features to look at, but we now focus on the smile. And when she got older, she looks like this. She's not able to show her upper front teeth again. And this, I copied this from a French newspaper, and it says that her husband has left her. Not so nice of her husband, of course. And she was crying, and she said, my husband was the son of the Madrac. That's a part of France, and the sun is not shining for me anymore. So we as a dentist can make a difference. And maybe we can do something for Brigitte Bardot. But probably, if you want to change this, is not only a dental matter, but you also need some peri-oral surgery, maybe. So the first keynote in the lecture is periodontal treatment always before orthodontics. You already knew that, but sometimes I see, at least in the Netherlands, that patients are not in a healthy condition, and yet the orthodontist starts to treat. Everybody knows it, but sometimes you don't do it. And you will always regret if you do orthodontic treatment without taking care of the periodontia. And the second keynote is that consider also lower teeth in smile considerations. Now let's have a small talk on the movement of the gingiva if you do orthodontic treatment, and then move on to how we can move the gingival margin using periodontal plastic surgery. Now, if you extrude a tooth, or you do a so-called forced eruption, then the connective tissue attachment and alveolar bone follow the extrusion pattern. So you take the bone with you. If you extrude, you take the bone with you. This can be an advantage if you want to create extra bone, for instance for implant dentistry, if you want to extract the tooth afterwards. But if you extrude for orthodontic reasons, then you have to think where your gingival margin should be in the end, because the gingiva also increases and follows 80% of the vertical movement you are making. As can be seen here, this was in a child, the front tooth was extruded, and the gingiva comes with it. How can we prevent the movement of the gingiva? If you extrude and you don't want the gingiva coming down as well, what should be done? You should do a circumcision every 2 weeks of the supracrestal connective tissue. So you should make a circumferential incision, just in size, and the gingiva will stay in position. So during the extrusion, you can do this yourself as an orthodontist, or if you prefer, you can send it to the periodontal department, and they make the circumferential excision, 1 millimeter, 1.5 millimeter from the gingival margin. And if you don't do so, you have a second chance, but then you have to do more extensive surgery on the child, and that is to surgically remove the gingiva. Okay? Hey Jay, there's a beautiful lunch waiting for you there, so why don't you have some nice food before it's cold? You have to perform afterwards, so be in good shape. Yeah, are you fine? You sure? Now, talking about intrusion, if you intrude a tooth with subgingival plaque and inflammation, this will cause infrabony pockets and infrabony breakdown. Animal experiments show that you can get, if you intrude, you can get new periodontal attachment, but it's only if there's no inflammation. You need a perfectly healthy situation. That's what were experiments in animal, so this is very uncertain if this happens in the clinic as well. And the gingiva moves 60% of the distance of the gingiva. That's good to know and sort of calculate where your gingival margins will end. Excuse me. Now you can of course, thank you very much. You can of course do an intrusion for crown lengthening procedure. As you can see, tooth number 1-1, the upper right central incisor, is shorter than the upper left one. And to most patients, asymmetries, if we will see later on, asymmetries are, and it's not equal. This is often very disturbing to a patient. And this is what if you show this to expert panels or to lay panels, they will also tell you this is not a nice situation. So what you can do is to intrude this tooth This has been done on the picture upper right. But then you need a second procedure with composite or porcelain, with a veneer, to correct the incisal edge. So this is a much more... Is this better? Oh, okay, okay. Thank you. Raya met een rietje. So you can get beautiful results. There's nothing wrong with that. The only thing is that's an extensive treatment. You need an orthodontic treatment, which takes time, costs money, and then thereafter you need a restorative treatment. This can also be done in a different way, and that's by means of periodontal plastic surgery. Now, before doing so, we should have a look at the most ideal situation. This is the mouth of one of my former dental hygienists, and one of the key things is that the gingival line, so the line through all the tops of the gingiva, should follow the upper lip line. And the incisal line follows the lower lip line. So this is sort of ideal situation. If a patient comes in and see you for the first time, this is something you immediately as a dentist will see or have to check and think, okay, this is nice, or maybe it's a little bit less nice. The most important feature is that there should be horizontal and vertical symmetry. There are a couple of other things. The long axis of the teeth are very important. If you orthodontically treat the teeth and you don't take the long axis, and there's a deviation in that, you will end up with an anesthetic situation. I'm having a look at my orthodontic colleague now and then, and I'm happy that she confirms what I'm saying. So horizontal and vertical symmetry are very important features. And another rule is that if you draw a line from one cuspid to the other, this line should be equal with the gum position on the central incisors. So what the Americans say is cuspid, central, central, cuspid. This is the horizontal line. And this horizontal line, in the ideal situation, should be parallel to the pupillary line in your eyes, and it should be parallel to the commissure line, so the edges of your mouth. Okay? This should be parallel. And if somebody has, for instance, a mouth that's not quite parallel, the edges of the mouth, then you can compensate a little bit in changing the incisal edges in a way that this is not disturbing anymore. Now then the position of the second incisor, lateral incisors, is approximately 1.5 meters below this line. Now this patient came in and she was not satisfied with her smile. This is a colleague from the hospital in which we're working, UMCG. 11,000 people are working there, so it's a big institution. Some of you who have been in Groningen for some time, they will know. And she came to me and she said, I'm not satisfied with my smile. Now here this is enlarged, and you're now able to do the analysis yourself. Is there a line, cuspid, central, central, cuspid? No. Is there an asymmetry? Yes. And you will also see, and please pay attention to the way she is smiling now. And I will also show you, of course, when the case is finished. And this also totally changed her smile. Not only the tooth display, the amount of tooth material she is showing, but also the perioral tissues, the tissues around. They also take a different position, more spontaneous. So what we did here is a crown lengthening procedure. And then you always need to know where the position of the bone is. And that has to do with the biological width. I think you are familiar, or most of you probably are familiar with the biological width. I'm always explaining to patients what the biological width is, saying that this is the genetically determined distance, minimal distance I should say, between the margin of the gingiva and the position of the bone. Genetically determined minimal distance of the margin of the gingiva and the position of the bone. And these are the three components of the biological width. That's the sulcus, the epithelial attachment, and the connective tissue just coronal of the bone. Now what will happen if you say, I want to make this tooth 2 millimeters longer, and you cut away 2 millimeters of tissue? This will grow up again. It's a matter of time. Within 3 months usually, the tissue will be in the old position. So if you like to do, and you have a patient who likes surgery every 3 months, this is the way to do it. If you have a patient who doesn't like to have surgery every 3 months, then you have to do something different. What should be done? You have to cut away some of the bone. And the only way to cut away some of the bone is to open up the tissue. So to raise the flap, small flap, open up and remove alveolar bone, supporting bone of the teeth. So if you want to make this tooth longer for 2 millimeters, for whatever reason, then you have to remove another 2 millimeters of the bone in order to restore the genetically determined minimal distance of gingival margin and the alveolar bone. So we start with just cutting away the amount of tissue that's needed to be cut away. Raise the flap and correct the bone. Here you see, you can do that with a burr, sterile salina to rinse, but you can also do this with hand instruments, with an excavator or a chisel or whatever. Cut away the bone, and you see that I'm cutting away the bone here. And I'm always joking that this is a very painful situation. Not for the patient, but for the periodontist. Cutting away healthy periodontal support is hard for the periodontist to do. We most of the time do so much effort to get new bone and to maintain a healthy situation. Now we're cutting away healthy bone, but this has to be done, otherwise you won't have a proper result. This has to be done. Here you see that the sutures are internal sutures with a knot on the palatal side, which looks nice for the patient. If you don't see any sutures during the healing period, you have to stay in place for 1 week. And this is the end result. And I'm showing this case because it's not perfect. Because there's a difference between the 1-1 and the 2-1. It's not completely equal. So I said to her, I would have said this to every patient, but since he was a colleague from the hospital, from a different different department. I said to her, I will correct on the 1-1 again. I'll do this for free because it's not perfect. And then she said, no, I'm totally happy with this situation, and in part this is me. And if it's too perfect, it's not me anymore. This is how she smiles now. She has a different exposure of her mouth, and she says, there was always a bit asymmetry in my mouth, but this improved to a great extent, but I'm still keeping some of my characteristics, and that's something you often hear patients say, and it's important also to consider. Don't make it maybe too perfect, so keep the characteristic and remove the caricature. So everything that's over the top should be corrected, but there should be some characteristic aspect of the patient should be kept. Now this is another example of modern adult orthodontics. The orthodontist is very much taking care of the long axis of the teeth, bringing them into the right position, and the orthodontist is not bothering about the gingival margin, because he or she knows that they can send this to the periodontist to make a correction on the periodontal level, and he or she orthodontic colleague is not concentrating on the incisal edges as well. This looks nice on the model, but if you only concentrate on the incisal edges without taking care of the long axis, then you will end up with a result which is not perfect. So this is the end of the orthodontic treatment. Then I was asked to make a correction on the gingiva, the gingival margin. So we had a crown lengthening procedure on the one central incisor, and on the other having a root coverage procedure. And that is carried out in the picture below. And now the gingival margin is in a nice position, and now the people from the prosthodontic department can finish the job, and they make nice composite fillings to get a nice correct incisal edge. So the keynotes here are, please consider periodontoplastic surgery, most of the time in combination with restorative dentistry for crown lengthening. It's a very fast procedure. It's a procedure mainly saying without any main complications. It's not very painful for the patient, fast healing. And then the other important thing is consider patient characteristics. Now we move on to gingival recession. We have a lot of gingival recession, and this is increasing, especially in younger patients. Younger patients brushing their teeth many times a day for cosmetic reasons, not to have a nice smell and that kind of things. But then sometimes they are doing this too much. So one of the main etiological factors is too much brushing, especially when you brush on the gingiva. Some patients believe that they have to brush the gingiva as well, but the only thing is that you should brush your teeth. It's called tooth brushing and not gingival brushing. So don't recommend to brush on your gingiva, but only on your teeth. If patients brush on their gingiva, then they will develop gingival recessions. Orthodontics is another reason to get gingival recession. I will come back to that later on. Let's first have a look at the traumatic brushing. Predisposing factors are a thin biotype gingiva. Some people have a very fragile gingiva, which is damaged much easier than this thick biotype of gingiva. The small apical basis, also called tooth size discrepancy. I'm always explaining this to patients. Either your jaws are too small, or your teeth or your roots are too big. And if so, what will happen? The teeth will take a position in crowding, otherwise there's no space for them. So this tooth-size discrepancy will cause a crowding, and most patients don't like crowding. So what they do, they see their dentist or their orthodontist, and what the orthodontist does is pushing these teeth to the edge of the alveolar bone. While actually there's no place for the teeth. Most patients don't like an extraction. If you have too little space, then in many cases it is of advantage to extract the first or second premolar. Nowadays, at least in our country, the parents say, no, can we do this without an extraction? I don't want healthy teeth extracted, and please try to fix it without an extraction. But then you easily come into the danger zone if you have a tooth-size discrepancy. You have to be very careful in your instructions for toothbrushing, because if these teeth are pushed to the outside of the alveolar envelope, the alveolar bone, and you have a thin biotype and you have a traumatic brushing, then for sure you will develop gingival recession. Sometimes you can see at a patient whether he's left or right-handed. Most recession is on the opposite side in the mouth. We did at ACTA, Tita already mentioned, we did a long time follow-up, 20 years follow-up study on gingival recessions. So patients came in with a gingival recession, and then we followed them up for another 20 years, see what would happen without any treatment. So see what the natural history of gingival recession was. The only thing was that we learned them atraumatic brushing. Here you see a single hand-tuft brush. Show them how to brush without damaging the tissue. So from, I always say, from red to white with this movement. That was the only thing. That was the only thing. No other treatment. And then after 20 years we see something very interesting. The majority of the sites didn't show any progression. This can be seen here. It's stable, including the green bar. There's a decrease, and there's also a decrease of more than 1.5 millimeter decrease of the gingival recession. So the gingiva is creeping up the tooth. That's why we call it creeping attachment. Creeping attachment. So it's so stable that it's even spontaneously the amount of recession gets smaller because the gingiva is growing up. And there's only a minimal part. There's only a minimal part that has a severe increase. Has a severe increase of, say, more than 1.5 millimeter. So on the average, it's very minimal. As you can see here, it's only 0.3 millimeters, but on the average, it's not very interesting. You should look at the individual side. so that only a minimal amount of sites show an increase of gingival recession. Here you see a female, 30 years of age, when she came in with a gingival recession of just 1 millimeter, but it was a tooth in a buccal position with ectostema. And when I was in school, we were told these are the teeth. If they have a recession, it gets always bigger. So you have to do something about it. And then we saw that if you remove the traumatic brushing, after 20 years, this is completely stable. This is the same patient. Completely stable. So, the next keynote is gingival recession generally only shows minimal progression over a long period of time. The funny thing is that patients are usually very, very concerned if they have a recession. They're much more concerned about having a recession than having a deep, inflamed periodontal pocket. You really have to explain them that they should be concerned having a deep periodontal pocket, because they don't usually feel any pain or any discomfort. So you have to persuade them to get treated. And most patients demand treatment if they have a recession, but in many cases you don't have to treat. Now we'll talk a little bit about gingival retainers, and these are investigations by Annemarie Renkema from University of Nijmegen. I also participated in some of the studies included in this thesis, showing what an orthodontic retainer can do. First, I'd like to show you one of my patients. She came in with a situation like this, and I'm sure that the orthodontist did not finish treatment leaving her in this condition. As you see, there's a big lingual torque of one incisor and a buccal torque of the other one. So what might have happened? What might have happened is that in this situation, there's the gingival retainer, or the orthodontic retainer I should say, has an active force still in it. It works like an orthodontic appliance, moving one tooth to the lingual side and moving the other tooth to the buccal side. Here you see another patient, 20 years old, orthodontic retention for 4 years, cuspid bonded twist wire, and she develops a gingival recession on the 4-1, as can be seen here and here. What you also see is that during articulation, this 4-1 heavily articulates. And what she does during articulation is she is giving buccal torque to this 4-1. So what we did is make a correction on the occlusion and articulation in a way that there's no contact during articulation, and this lingual retainer cannot act any longer as a fulcrum. There can also be mouth habits. Here you see a severe recession also on the 4-1, and we couldn't find any disturbances in the occlusion and articulation. And then she said, "Yeah, I have to tell you something, doctor. At night I'm still holding my thumb in my mouth." And there are more patients probably also in your practice doing so without telling you. But it's always important if you see on one tooth, you see a recession developing, that the patient is not by pushing with the thumb, moving this tooth in a more forward position. So if you think you have an active retainer, which is in many cases there, then the first thing is to remove this lingual retainer. There's a tendency now in the Netherlands to remove the retainers, especially lingual retainers in the lower front teeth, at the age of around 25. If these patients have been treated in younger age, then after 25 they just take out the retainer and then it all stays stable. Then you have to observe the hygiene. You can do an orthodontic retreatment. You can consider periodontoplastic surgery and giving this patient a night guard. So remove the retainer, take care of the oral hygiene, do some root planing if necessary, do some cleaning. Orthodontic retreatment once the periodontal status is healthy, and then you end up with this situation. And then you can ask yourself, when shall I do periodontoplastic surgery? There can be an indication because it's very difficult for the patient to clean. If you have one localized gingival recession, this might be very difficult. It could also be that this tooth is very sensitive to cold and sweet and hot drinks. This could be also an indication for periodontoplastic surgery. And it could also be an aesthetic consideration. Now, when doing aesthetic cosmetic surgery in general, there are always a few things to take care of. You should always consider psychological factors. There are patients with BDD, body dysmorphic disorder. They concentrate so much on one particular small aspect of their body, and you will never be able to satisfy these patients. So be very careful and be very much aware. It would take too much time to go much deeper into that, but take care of the symptoms of BDD. And the oral surgeons also know that when they do orthokinetic corrections of the lower jaw or the upper jaw, they do major surgery to give the patient a different profile. If you think this could be a BDD case, please send them to the psychiatrist or send them in for psychological health and consultation first. And that's also for the cosmetic treatment in the oral cavity. Some patients, you get a perfect result and they're never satisfied. They call you up, never give them your cellular phone number because they call you during the weekend and at night complaining about all kinds of different things. Of course, there are surgical risk factors to consider. That's smoking, anatomy. I told you about the position of the tooth. If the tooth is in a too much buccal position, you will be unable to cover this tooth with gingival tissue. It will go down again, and you have a relapse after a short while of time. Then you have to evaluate and to do the Miller classification. I'll come back to that in a second. And you have to make your choice of surgical technique. Now the Miller classification, if you have a Miller class 1, then the gingival recession is not beyond the mucogingival junction. It's not beyond this junction, the margin between the epithelialized and non-epithelialized tissue. In class 2, the recession goes beyond or is just up to the mucogingival junction. In the class 3, there's also interdental loss of tissue. If you have to do this interproximal stripping first. And in the class 4, there's interdental tissue beyond the gingival recession. And usually in applying any type of surgical treatment, you will be very successful in Miller 1 and Miller 2, and you have a limited result in class 3. And in class 4, you hardly will have any clinical result of any clinical significance. So that's good to know. If you start to treat a patient, everybody likes nice results and predictable results. So you really should have a look at the Miller classification before you start. Here you see a patient in the retention period after orthodontic treatment. And nobody has seen that a gingival recession on the 3-1 had developed in a 7-year period. Which again shows that you have to actively look for the recession in the gingival margin. You only see during your examination what you are looking for. If you are not aware of any other pathological conditions that could occur in the oral cavity, then I know colleagues, they say, I never see lesion planus, or I never see whatever pathological condition, not even starting carcinomas on the tongue. If you don't inspect the tongue, then you don't see any thing abnormal. So you have to actively look and actively see what's going on in order to be able to interfere at an early stage. So, keynote is check the orthodontic stability and the position of the gingiva. And the orthodontic stability is not only on models, on cast models, but also actively in the mouth and see how the gingival tissues behave. And beware, always beware of retainers in combination with occlusal factors and mouth habits and patient factors. Now we come to the procedures how to cover a gingival recession. Basically, there are many techniques. But basically, there are two techniques that we apply in the clinic, and that's a free connective tissue graft, and that's a coronally repositioned flap procedure. Now, the coronally repositioned flap procedure, it's a quite simple technique. You make vertical incisions on the side of the tooth. You raise a flap. You cut the periosteum, then you get a mobile flap. Otherwise, you're unable to push this to more occlusal or incisal position. And then you see you have a very mobile flap, and then you adjust the gingiva a little bit, and you suture this at a few spots. But before you're doing so, you apply what we call Pref gel. This is nothing else than EDTA, which is also used in making slides at the histological lab. Doing so is decalcifying the bone or the dentin, in this case the dentin. You are decalcifying with the EDTA. This is on the market in Europe under the name of Pref gel. It's very cheap, but you can also use EDTA, ask your pathologist to get some EDTA. What you are doing actually is removing the smear layer, sterilizing the tubules, all bacteria that are in the tubules that will be kicked out by applying this EDTA. And you'll expose the connective tissue in the dentin. And now comes the interesting part. While exposing the connective tissue in the dentin, the connective tissue in the gingiva, they can make a reunion. They can attach to the connective tissue of the dentin. So you remove the recession without creating a deep periodontal pocket. This is the last thing you would like to do. Just cover up the root, and while in doing so, making a deep pocket with substantial plaque growing in, etc., etc. No, you want it firmly attached to your tooth with a very shallow pocket which easily can be cleaned by your patient. And that's what happens. Here you see that this is attached to the interdental papilla, and the releasing incisions are sutured as well. This is the result after 3 months. You see it's a beautiful blending of the tissue before and after. Here you see a lady with deep recessions, large recessions on the cuspids, and these recessions were very much disturbing to her. She was not disturbed about this lateral incisor here. Say, well, we can do something about it. We can apply a little bit of composite, make it more nice. No, she said, this is my characteristic, but not the recessions. I didn't have any recessions, and they gradually developed, and now I want to get rid of these recessions because that's not me, and the position of this lateral incisor, that's me. Again, patients like characteristics, but they don't like caricatures. So we remove the caricature by treating these recessions on the cuspids. Here you see situation after treatment, and she was very happy about this. Nice coverage of the recessions on the cuspids, and it's a very stable result. This is situation after 1 year. This is on the other side after 1 year, and again you see it's a beautiful blending of the tissue. You have this festoon-like tissue before, and by a typical repositioned flap, it will end up in a nice blending of the tissue. So in the maxilla, the coronally repositioned flap usually is the method of choice, giving a long term and a predictable, long-standing result. In the mandible, connective tissue grafting usually is the first method of choice. Here you see a 31-year-old female after orthodontic treatment. She developed an 8mm recession during the retention period, as is clearly demonstrated in this clinical picture. There was a twist wire, and you also can see that the 3-1 had a big labial torque. So it was in the buccal position, and especially the root was in the buccal position, which causes the gingival recession. The orthodontic retainer was removed, and the orthodontist took care of lingual torque of the 3-1. It can be seen here. The root was covered using a connective tissue graft, showing a nice result, and this was stable over the year. Now this is speeding up a little bit because otherwise we'll run out of time. This is the situation before. Here you can see this is really a situation where this root is pushed to the end of the alveolar envelope. Now, here you see that this is really a difficult case. And this has been treated by one of my colleagues using the microscope, because this needs very subtle and very sophisticated microsurgery. Here you see the graft is harvested from the palate, it's sutured, and the graft is by means of a tunnel technique, it's put into position. And here you see just after suturing, and this is the end result. And she's coming in for monitoring the situation, and this is now stable for at least over a 2-year period. If you show the patients not to use this dramatic brushing and the tooth is in the proper position, then this will be stable. Recessions in the lower jaw are often related to an active working retainer. That should be kept in mind. And the treatment involves removal of the retainer, often retreatment as it comes to orthodontics, and periodontoplastic surgery, including connective tissue grafting. Loss of interdental papilla, black triangle disease. What can be done? What can we do? Of course, we can do orthodontic treatments. Stripping, in this case, this was a very quick solution. Does anybody see what has been carried out here? Are you familiar with the gingival epithesis? Or, as the Americans call it, party gums? It's sort of acrylic material, and that can be clicked in to cover up for the black triangles. You put them in when you go out, you have a party, so that's why it's called party gums. Now I have 2 more cases to show. This will be very short. This patient was referred by a general practitioner to me, asking for root coverage of the upper incisors. Is that a good idea? You know how to analyze now. Will you end up in a nice situation, you think? What I did is a crown lengthening procedure first. A crown lengthening, that's something totally different. And you have to inform your patients that first it's going to be more ugly, and then in the second step it will be more nice. And you have to have a very close cooperation with your dental technician, and this is the final result with porcelain crowns. First bringing the gingiva in the right position, and this is before and after. So this is a totally different situation. This is the last case. This young man was treated in the clinic in Amsterdam, where I work for 1 day a week. This is the gingival situation, and this man had to talk to people a lot, and he felt ashamed of his teeth. So here you can see this in a close-up situation. Now you do the analysis. This is not a cuspid, central cuspid situation. There's 2 less tooth display, there's a gummy smile, etc., etc. There's a diastema in front. We start with a digital smile design. This is very cheap in a program you can install on your laptop. You import the clinical pictures of your patient, and then you can start playing with the dimensions. And then you even can show your patient what the end result will be and how you're going to make it. You can make a mock-up, etc. I'm not showing you this for for time reasons, but this is the digital smile design. And this was the information I got from the prosthodontist, because he said this is the end situation I want to have. So could you make corrections on the gingival margin in a way that you cut away, do a crown lengthening procedure on these teeth, giving them more tooth exposure, and then I will finish the job, he said, the prosthodontist, Paul de Kok from our clinic. This is after my gingival correction, and what we always do is after 1 or 2 weeks with a little bit of composite to make a situation which is more nice. Then we wait for a stable position of the gingiva, and then the porcelain crowns are made. And this is the end result, and he's laughing in this way now. So this is a totally different appearance as from the start. So the keynote here is that a multidisciplinary approach in a team of an orthodontist, a periodontist, and a prosthodontist is needed for the best result. And with this, Dr. Tita, I would like to give the word back to you, and I thank you, my dear colleagues, very much for your kind attention. Thank you.